Friends, I'm happy to be here at the invitation of the Apollo Hospital Group to give you an update on critical care nutrition. Now, during my long career, I have been working in Chennai in the former Tamil Nadu Hospital and also at Ramchandra Medical College. And so, what I'm about to tell you is something that can be done in our hospitals here in India, not necessarily based upon my experience of practice for the last few years in the US. Also, I'm giving you my email address so that you can communicate with me, and I'll be happy to share my slides with you on an individual basis. Even though some of the material may be copyright, so be careful when you use it, because I believe strongly in the concept of train the trainer. We have a lot of information to actually cover in these 20 minutes, but I will try to do justice to the time that is allotted to me. And to start off by introducing a term called implementation science. It takes an average of 17 years, would you believe it, for evidence to change practice patterns. So, in the field of critical care nutrition, it is not only a gap between evidence and practice, but it is a huge, gigantic chasm which actually is very frustrating to say the same things year and year again for the last several years. For example, you would have heard so many people talk about not listening to bowel sounds before we feed a patient in the ICU, and yet there are physicians who still believe and nurses who still believe that bowel sounds are needed. Similarly, surgeons telling you that you have done a GI anastomosis, therefore you should not feed the patient waiting for bowel sounds. It is absolutely ludicrous because the evidence has been shown several decades ago that it is not needed at all. So we don't want to wait for 17 years for practice patterns to change, and I want you to be forceful enough to make sure that these changes are reflected in your hospital itself. Only 1 out of 5 evidence-based interventions make it a routine clinical practice, which is quite sad. The term implementation science is used in several non-medical areas too. In colorectal cancer screening, gestational diabetes, we know that there is strong evidence, but yet it is not practiced. Even general practitioners and primary care doctors don't insist on colonoscopies on anyone over the age of 45 or for mammograms or for just management of gestational diabetes. And I'm not worried about preventive health and community-based nutrition. Our interest is critical care nutrition. And there's been a push now that at least 10% of funding for all research activities should be reserved for interventions or the implementation of what we have learned. It's sad that so much of money is spent on so many research projects, but very little actually impacts the actual health of the patient. Here is a nice review to show that implementation science specific to nutrition must be practiced from research to practice. And to prove that point is the well-quoted EFFORT study which was published in Lancet 3 or 4 years ago. EFFORT stands for the effect of early nutrition support on frailty, functional outcomes, and recovery of malnourished medical patients trial. EFFORT. This was an open label multi-center study. It is true this was done on medical patients, many of them non-ICU. But what was learned from the trial can also be extended to our own practice in the intensive care because it's a huge trial. Huge number of patients were looked at. And the trial was what happens in real life when you screen the patients at the time of admission, at the time of ICU admission. And an assessment is done as rapidly as we can. And the nutrition therapy for your patient is individualized, either enteral or parenteral or combinations of the two or even oral. Then you will find that the patient has a lesser chance of dying in the ICU, leaving the ICU sooner, and also not getting readmitted to the hospital after discharge, which can only be done, my friends, with the help of a team. However good you may be as an intensivist, you cannot do all this without the help of a dietitian. I grant you this study was done on trauma and surgery patients and mainly patients on enteral nutrition, but when you have a team approach, you will find that the percentage of nutrition delivered improves significantly to 85%. and the percentage of patients who received more than 80% of the goals increased from 53 to 65%. So you need a formal nutrition support team, and in the ICU you will be the leader, but you must always have a well-trained dietitian who can actually help you in these methods. And for that, I now bring you to the diagnosis, the recognition of malnutrition in the ICU. Now, if you have a patient with let's say meningitis, and you say, oh, I'm not going to treat it, that's medical malpractice. So if you document that the patient has malnutrition and you don't appropriately treat it, that is medical malpractice. And to make it simpler, the GLIM, the Global Leadership Initiative in Malnutrition, about which I'll talk to you in a minute, has come into the picture. I would urge all of you to go back to your hospitals and to abandon all other methods of nutritional assessment. Follow the GLIM criteria, because it requires one etiologic criterion and one phenotypic criterion. The phenotypic criteria are the ones you know of: weight loss and low BMI, and weight-based equations, and weight loss is totally unreliable at ICU. So we come into the etiologic criterion, especially disease burden. Disease burden malnutrition is now captured. You have one etiologic criterion, one phenotypic criterion, and lo and behold, you have the diagnosis of malnutrition, which gets registered into the patient's medical records. This has been shown in various aspects of medical care, including the ICU. And this was made by an international consortium. So you can't say, well, these are North American guidelines or European guidelines. They are quite suitable for Asia also. It does not actually use weight, but it captures disease-related malnutrition, and it actually captures sarcopenia, about which we'll talk about it in a minute. And the obese patient. Now, if you have an obese patient and you tell the family the patient is malnourished, they will laugh at you. But the truth of the matter is, an obese patient may be malnourished, and that conviction in your mind that an obese patient can also be malnourished, and convincing the family and convincing all other specialties, as an intensivist, you'll be the best person to convince other folks who may not keep up with the literature, is the most crucial thing to document the diagnosis of malnutrition. Protein loss occurs in ICU patients, as you are well aware of. Almost a kilogram of protein is lost. It occurs in elderly patients, post-operative trauma, brain injury, bed rest, all aspects of critical care. And you not only have sarcopenia, you have the sarcopenic obesity and a condition called myosteatosis, where actually the muscle looks big but it is filled up with fat. Now, I agree the diagnosis is not easy, but the intensivists are absolutely great in using ultrasound, point of care ultrasound. I urge you to use ultrasound of the quadriceps femoris muscle, added to the functional assessment with hand drip dynamometry in non-sedated patients. The combination of the structure of the muscle and the function of the muscle, we can pick up frailty in obese patients. Those of you who are interested, here are all the various publications that are available, several more publications too, showing that ultrasound, which in our country can only be used by a physician, no one else, can be used to detect and to monitor sarcopenia in the ICU. I will strongly urge you to do it, because this is a very, very new development. Now, we must also emphasize the continuum of care. You might say the patient is mine only when the patient comes to the ICU. Not true, because many times the surgeon may call you and say, look, I'm doing a major procedure, or the gynecologist may call you and say, I'm going to do the debulking procedure on Monday. Do you have a bed in your ICU? Then you can ask the surgeon, has the patient gone through a prehabilitation program? Has the patient been evaluated by a nutritionist? It may be even a telenutritionist by remote monitoring, 7 to 10 days prior to elective admission, which includes, of course, physical therapy and counseling with matters related to nutrition, using oral nutrition supplements, about 500 cc's a day alone for about 7 to 10 days prior to an operation, prior to admission. And in some hospitals, I know that in addition to anesthesiology clearance and a critical care clearance and perhaps a cardiology clearance, you need a nutritional clearance, nutritionist clearance before the patient can even be scheduled for surgery. And we are not too worried about the 30 days post-discharge evaluation, Even that has been shown to be cost effective, but your role as intensivist will be to insist upon prehabilitation. And the reason I put the word tele there is because this can be done even by distant monitoring of the patient. Now, I want to go through several aspects of critical care nutrition which are pertinent in this short segments. The first is the abuse of albumin in the ICU for nutritional purposes must be given up. I'm sorry, this slide on prehabilitation was actually supposed to be earlier to show that it can be done with abdominal surgery. Now, coming back to the albumin, there is a relationship between inflammation and serum albumin. When the albumin level goes down, it is because of inflammation. It is not because of malnutrition per se. Similarly, the prealbumin level may actually go up with inflammation, so you cannot actually rely on prealbumin or albumin for diagnosis of malnutrition. Now, this slide actually shows that so many acute phase proteins go up and go down, and albumin level is one thing that goes down with stress. This is a New England Journal of Medicine paper, just came out a few weeks ago, and therefore, it is true that during the perioperative period, albumin level goes down because the liver does not want to make albumin anymore. The hepatic reprioritization is to make other acute phase proteins, and therefore albumin levels do not help in preoperative risk stratification. It should not be used as a marker of malnutrition. And while you give the patient nutritional support, it does not assess the adequacy of nutritional support too, and therefore it should not be used in the adequacy. So much so, the Society for Critical Care and the American Society for Parenteral Nutrition in 2016, as shown in the red line there, issued a statement to say, do not even measure serum albumin levels for nutritional purposes. You might want to give albumin for hemodynamic instability. But the sad part is physicians still use albumin. It is low, and therefore you give albumin at 4,000 rupees per dose, maybe 3,000 rupees. And then the very physician who uses albumin when it is not indicated for nutritional reasons declines to spend about 100 or 200 rupees on enteral feeding. Therefore, please abandon the use of albumin. That comes to another aspect of fluid balance. Is fluid balance has anything to do with nutrition? Absolutely yes. This is a slide just to highlight to you that in acute pancreatitis, like in various conditions like sepsis and trauma, we have seen that restrictive fluid resuscitation works. And one of the benefits of restrictive fluid resuscitation is that early oral nutrition can be started. And in this particular study, compared to 48 hours in the resuscitation group, oral feeding or enteral feeding could be started within 20 hours itself. Therefore, I urge you to follow the practice of restrictive feeding. Another complex thing in critical care is energy requirements. Earlier, we used to give 20-30 calories per kilogram. The new guidelines clearly state that you start off with only 12 to 25 kilocalories per kilogram per day for ideal bodybuilding for the first few days. And you might say for the first 7 to 10 days, a little bit vagueness. Some people may say just 5 days. Gradually increase the calories. Don't use predictive formulas. Harris-Benedict equation is 145 years old, of no use at all. Just the rule of thumb is absolutely fine. When higher protein requirements are actually met of 1.5 kilograms per kilogram per day, then the amount of calories you give a protein becomes, the amount of calories you give the patient becomes less important. Now, giving low protein in the earlier part of the ICU fits in very well with the philosophy of you cut down protein in the earlier part of the ICU care. In the first few days, you give less calories. You also give less proteins, and gradually, as you increase the calories, you also increase the protein to make sure that the non-protein calorie to nitrogen ratio is kept the same. It coincides with gradual increase. A gradual increase is very important because you don't want the patient to develop refeeding syndrome, about which I'm going to talk about, and electrolyte imbalance is more important, glucose control too. Some folks may say, what about indirect calorimetry? Now, I would say that if every aspect of nutrition care is absolutely perfect in your hospital, prehabilitation, and good nutrition therapy, enteral feeding, early initiation. When everything is done, then you might want to invest in an indirect calorimetry. But even in several US hospitals, including the entire US government hospitals where I work in, it is not being used. Why? Because it is not readily available. You need a trained respiratory therapist in the majority of instances. They are not usually available, and there are limitations and optional requirements. The guidelines often recommend, but they actually say where available. And even in Europe, where it has been popularized, in many patients who are deemed to require indirect calorimetry, it is not used at all. And so it has also been shown that interventions adjusting calories alone do not generally affect outcomes if the protein intake is actually high. So I would urge you to use this only as a research tool when possible. When everything else about nutrition is absolutely hunky-dory and perfect, then use it, not otherwise. Volume-based feeding is very interesting because you give the amount of volume per day, not per hour, and then the nurse is able to adjust the increase. And there are several publications on this. The guidelines actually say it, and also there are publications on volume-based feedings from the Apollo Hospital group itself. It can be absolutely done, and it should be the way you practice volume-based feeding, because continuous enteral feeding has been shown to even cut down diarrhea. In the ICU, bolus feeding should never be used. Unfortunately, bolus feedings are used in some of our ITUs through large bore feeding tubes, and worse still, kitchen prepared diets are used in many hospitals thinking it is cheaper. Nothing is further from the truth. Kitchen prepared diets have been abandoned everywhere else in the world, at least in the Western Hemisphere. It should not be used in any ICU patient. It should not even be available. Only scientific formulas should be used. We come to the other interesting group of slides on enteral feeding in the prone position, ECMO and neuromuscular blockade, and suffice it to say only the references are quoted here, including one from the Apollo Hospital group, saying that enteral feeding is perfectly possible in the prone position, even intragastric feeding, well tolerated. Protein delivery is almost the same as that of the supine position. In hypotension, as you very well know, if the mean arterial pressure is 50 millimeters mercury, absolutely safe to do it. However, if the pressure is very low and the pressor needs are increasing, the serum lactate is increasing, then I would not use enteral feeding in hypotensive states. Start of even giving the patient small amount of calories, 5 cc, 10 cc per hour, subtrophic feedings I might call it. What about ECMO? Studies have clearly shown that ECMO is quite not a contraindication for enteral feeding, and you might want to use a concentrated formula of 2 calories per cc, slower rates, trophic feeding, and monitor for metastatic ischemia. Prone position is not a contraindication. Neuromuscular blockade is not a contraindication, as once again shown in this slide to show that neuromuscular blockade do not affect the smooth muscles of the GI tract, and therefore it is absolutely safe to follow enteral nutrition like in any other patient, even with neuromuscular blockade. What about gastric residual volume? Studies have clearly shown it has no relation to aspiration pneumonitis, ventilator-free days, mortality, or organ failure. Studies have shown there is no need to measure it. Even if you want to measure it, use it selectively when you have gastroparesis or for whatever reason, diabetic gastroparesis or maybe uremic gastroparesis. And in this study, it shows it can be used as a marker of GI dysfunction, but there's no correlation with ventilator-free days. A very nice paper just a few weeks ago, international study. There are other studies that have clearly shown that in the community hospital, measurement of GRV did absolutely nothing in terms of emesis, diarrhea, or glucohomeostasis. Adverse effects were not at all affected, so you can safely eliminate the measurement of gastric residual volume. If you want to, instead of 500, say, okay, 400 cc's is fine. Beyond that, you can serially measure it and use prokinetic agents if you really need. Now, unnecessary lab tests should be avoided because you want to avoid the anemia of chronic investigations. About 40 to 70 cc's of blood may be drawn every day, but only 2% is actually needed. And 30% of blood transfusions in the ICU. So don't get unnecessary labs in the ICU, especially use nutrition as an excuse to get labs. And use only specific entities, hemoglobin levels by hemoglobin, not complete blood count. The quality of care is not compromised at all. And here is another study just published a few weeks ago in Critical Care Medicine that reduction in routine blood tests does not produce any adverse reactions, except when you look at refeeding syndrome, about which you are quite familiar with, and I've written a chapter on refeeding syndrome in the textbook of critical care nutrition that is going to be published next month. Especially the use of phosphate and the use of thiamine. You start early with only 1.5 calorie per kilogram per day, and the use of thiamine in the first 3 to 4 days of an ICU care is very strongly recommended. 100 to 200 milligrams of thiamine are given in the early stages of ICU care. And thiamine deficiency can present as refractory metabolic acidosis, congestive heart failure, abdominal pain, and mental changes, confabulation, vernix encephalopathy. Don't ever forget thiamine deficiency. Micronutrients should always be used in critical care as shown in this Society for Critical Care guidelines, and this update which was published a few years ago shows clearly that we must always be careful about using micronutrients in every patient on parenteral nutrition. And this comparison meta-analysis with which I was proud to be an author says there is no evidence to support the use of mega doses of any micronutrients. So my concluding remarks are: recognizing malnutrition is very difficult in the ICU. I do agree, but use your subjective feeling and use your lab test, and you'll be able to provide good nutritional care to ICU patients. Thank you.